All right. So first, thank you all for coming, and welcome to the 2022 Vermont Public Health Association's annual meeting. My name is Ken Allen. I am the association president. It's just really great to be back together as a community. I just know that you all realize how stressful the last couple of years have been for all of us, and being separated has not really helped with that. And so it's just great to be together again and really connect with people on more of a human level, and sort of take this opportunity to also recognize some folks who have done some incredible achievements and talk about some really important issues that are happening in Vermont related to public health. So we have essentially 4 things on the agenda tonight. Because this is our annual meeting, there is a business portion to this meeting where we would like to give a little update about some of the work that the association's been doing over the last year, and it's a lot. I intend to keep that portion really succinct so that we can get on to sort of the main events. And the main events would include taking an opportunity to recognize and acknowledge 2 individuals and a team who have really made some extraordinary contributions to public health and protecting the health of Vermonters over the last year. And so we'll be recognizing our public health champions. We're also going to engage in a panel discussion related to mental health in Vermont, which I'm sure you're all aware have really been exacerbated by the pandemic and has really stressed our mental health system really beyond its capacity. So we have a panel of people that are closely involved with the mental health system in Vermont. And lastly, but not least important, we're going to have dinner. So I realize that right now I'm standing between you and dinner, so I'll make this next part as short as I possibly can. The big thing that we've been working on for the last year is we've engaged in collaboration with the Vermont Department of Health into a CDC health equity grants related to creating community collaboratives in each of Vermont's health districts. And while I could probably stumble through and give you some information about what we've been doing, I'm actually going to bring up Penrose Jackson, who is the director of the Vermont Public Health Institute and has really been overseeing the grant, to update you on what we've been doing there and where we're going with that. So, Penrose, thanks.
Thank you, Ken. So I can't see the slides. Who's driving the slides? Okay. So. What did I say? All right. Whoops. So we are the happy recipients of about $4 million from the Vermont Department of Health to establish and support a statewide learning collaborative to really look at health inequities, particularly those that were laid bare by COVID, by the pandemic. And the structure for that is we're working with, we hope, all 12 Vermont Health Department districts where they're establishing or working with existing coalitions to really look at this work, to develop some goals related to it, to evaluate what priority populations they want to look at. And we have the ability to also help staff the work. We're a half-time, full-time equivalent person in each of the 12 districts, and also there will be money that will be available through the districts and their collaborators to support local efforts that address the health inequities. So the dollars, I think, are there, but it's bright out and probably nobody can read it either. So I suspect you'll be able to have the slides afterwards. I think I have one more. What does that say? Kathy.
So just piggybacking a little bit on what Penrose said, one of the models, one of the key things of this grant is we're working in each district to focus on the needs of each district. So it's not cookie cutter model. And these are some of the partners that we have established working with. So in Bennington, it's the Bennington County Regional Commission. In Brattleboro, it's a partnership between the NAACP and the United Way Windham County, and then you can see the list here. What's unique about this grant is the local districts are deciding what they want to work on and who they want to partner with. So Penrose had mentioned hiring a backbone staff. So there's enough funds to hire a 0.5 FTE in each district to develop their local collaborative, figure out who's the organization that makes the most sense to partner with, and then the funds go directly to those communities based on what they decide that the grant money should go toward.
So we're going to keep things moving right along. So if you have questions about this, anything in particular, please don't hesitate to reach out to Kathy or me, and we will do everything we can do to answer your questions. Ken?
Yeah, so when Penrose approached the board of the association with this opportunity to engage in this grant, it initially started as about a $400,000 grant, and we thought, yeah, I think we can do this. We should really stretch ourselves and engage in this work. And over the course of the planning, it sort of ballooned into about a $4 million project, and with that came a lot of growing pains for the association and the institute. And most of that involved, we really had to establish and we had to build a lot of infrastructure to be able to pull off this work. And so a lot of the things that we've been doing over the last year is hiring 2 full-time employees, doing a lot of the things that, you know, most organizations would already have in place, like having a bookkeeper and having the ability to undergo an audit and having a contract with legal services and having things like employee handbooks and policies and procedures. And so we've really had to dig down and do a lot of work in sort of getting all of that set. And now we're really in a great place, a place that, you know, it really put us fast forward into a new place where we can start to do a lot more work and go after a lot more grants. And related to that, the next thing that we're going to do is we've engaged with an organization called Health Resource and Action. They're based out of Massachusetts, and essentially they used to be the Massachusetts Institute, Public Health Institute, and they do a lot of consulting and a lot of national work to help other organizations and institutes to address public health problems. And really what they've invited us to engage in is a strategic planning process where in a way they're going to help us to figure out what our vision is going to be, what are we going to do next, what kind of role do we have in the Vermont public health landscape. And essentially they've said to us, like, we want to teach you how to be like us. And I think it just kind of points out to me like the way the public health community works together and like not seeing each other as competitors or whatever, but really looking for ways to collaborate, and they really are supporting us. So we're going to be engaging in a really in-depth strategic plan that we started working on a few weeks ago. But as part of that plan, we want to really talk to people that are in the public health community, and we want to interview stakeholders. And I bring that up because quite a few in this room are probably on our list of people that we would like to contact. So when we reach out to you, please get back to us and give us a little of your time to help us to think about where we're going with this thing. Okay. Some other work that we've been doing is continuing our work with our policy committee and our communications committee. We've really written a few policy statements this year, but we've really gone back and looked at a lot of our other policy statements. And a lot of the ideas around our policy committee is writing these policy statements that individuals and organizations can then use as part of advocacy campaigns. And I bring that to you because I'm really asking for volunteers and help. You don't have to be a board member if you want to participate on our policy committee and advocate for certain policies and work on writing these policies. And if you want to work with our communications team, particularly if you have any expertise in social media, we could really use that. Please feel free. All you got to do is contact us and say you'd like to help, and we will put you to work. And just a few acknowledgments. One thing that I would definitely like to do is, given all the work that we've done this semester, is I'd like to acknowledge and thank our board members. So I know quite a few of you are here tonight. For our board members, would you please mind just standing for a second? Thank you. And I would like to give special recognition to Joellen Tarallo. Where's Joellen? Yes. I was wondering that I was going to do that. In her day job, Joellen is the executive director for the Center in Health and Learning in Brattleboro. She's been a board member since 2017. Is that right? That's what I figured out. And just want to really thank you for all the advice and help and support that you've given us over the years, and it's much appreciated. So thank you, Joellen. I want to recognize and introduce our operations manager, Kathy Eggman, and Kyra Wood. Where's Kyra? Yes, there's Kyra over there. So Kyra is pretty new to the organization, but she is our district liaison. Her job is to work with each of our district backbone personnel and the district directors around these community collaboratives, and I think of her as being sort of the glue that holds all that together. And I'm really glad to have Kyra on board. And Kathy started with us in January on a full-time basis, and I just can't thank you enough, Kathy. I mean, you have been amazing. She's so organized and detailed, and she keeps me on track. And I don't know why, but it doesn't matter if I email her at 6 o'clock in the morning or 11 o'clock at night or the middle of the day, she responds right away. So she's just always there for us. So just really wanted to recognize them. I want to recognize Chloe Jackson and Isabel Boutin. So Chloe and Isabel, they worked with the association as interns over the last semester, and they really went through our policies and reviewed them all and identified for us which ones we really needed to take a look at, and gave us suggestions about new policies, and they actually wrote a policy about reproductive rights, which you can see their poster back there, which we're about to approve that as one of our official policy statements. So thank you so much for your work over the semester. And I want to mention that Isabel is going to, she is been elected as the new president of the Vermont Student Assembly for Public Health. I always have trouble with that name. Yeah. And that person serves as a de facto board member of the Public Health Association. So thank you and welcome, Isabel. I was thinking Jackie Lumen, who's also one of our board members. She's a student. She's the current president. She's not here tonight, but thank you so much, Jackie. She's been at every board meeting and really has helped to give us the student perspective that we haven't had in the past. Also want to recognize, I didn't put them on the slide, but two other service learning students that we had, Colin O'Reilly and Andrew Slaughterback, and give them a little rise back there. So Colin and Andrew worked with Public Health Institute to create asset maps for the districts up in the Northeast Kingdom around mental health. So they've created this mental health asset map, which is now being used as the foundation for another map that the districts are going to build off of. And there's a poster back there, and it's really cool. They've got these new things. I know all the kids know about it. It's a QR code. You can take a picture of it. I only know about it through restaurants, but you take a picture of that, and you can have that map, and it's an asset map of all kinds of mental health resources. It's keyed and coded, and it's really cool. So thanks everyone, and thanks for all the students who brought posters. We just wanted to kind of I know when I was a long time ago, much younger, coming to meetings like this and being able to connect with people that would work in the field and being part of the community was like really important to me. And over the last few years where everything has been virtual, including like classes, I know that they just feel like they're not really connected, and really wanted to kind of bring them in and think about, like that's our future, right? Those are the people that are going to be taking over our public health work for us. And hope you had a chance to take a look at their posters and talk with them. So thank you all for all the work that you've done this year and for being here at this meeting. So thanks. I'm going to give a little clap. And so what we'll do now, one more thing, one last slide, I think. Yeah, I just want to bring up that the APHA meeting, which we're a chapter of the APHA. is in Boston this year in November. So really want to put a shout out to that and hope we see a lot of Vermonters down there at the meeting. I know I'll be there. I know some other board members are planning to be there. So if you can make that happen, you really should. It's a great event. And it's the 150th year of the American Public Health Association this year. So want to make sure we recognize that. Now, so the next thing is what we're going to do with a little bit of a change in plan. We're going to eat. It's going to be a mad rush to get back there. But if we could let the public health champions kind of go first so that we'll be ready for that, that would be really good. That's all these gentlemen dressed in their dress blues. Want to make sure they get there. Then once everybody mostly gets set back down, we'll start with the Public Health Champion Award ceremony. But so little bit of a change in plan. I didn't really realize it was going to be a buffet versus a service, so didn't want everybody getting up while we're trying to recognize people. So that's that for now. So in an orderly fashion. Let's not trample each other. Let's go get some food, and then we'll carry on. All right, thanks. All right, so let's move on with the main events of the evening. Let's start with the Public Health Champion Award. I'm going to call up Joellen Torello to introduce our first Public Health Champion. Thank you.
It is my pleasure to kick off the presentation for the 2022 Public Health Champion Award. The awards were initiated in 2017 by the Volunteer Board of Directors of the Vermont Public Health Association in an effort to increase awareness about public health, to bring attention and focus to a variety of public health initiatives in Vermont, and to recognize individuals and groups who have made extraordinary contributions to the well-being of Vermonters. This year, it is with great pleasure that I represent the Vermont Public Health Association to present the 2022 Public Health Champion Award to Dr. Mark Levine, appointed Vermont's Commissioner of Health by Governor Phil Scott in March of 2017. Little did Dr. Levine know, or any of us know, the significant public health challenges that lay just a few years ahead. Prior to the pandemic, Dr. Levine's work in general internal medicine and as a highly regarded educator and program innovator informed his perspective on the challenges the healthcare system holds for providers as well as for patients. This focused his interest on improving health at the population level through health policy, including work advocating for preventative health practices in primary care. Meanwhile, the challenge of a lifetime laid out ahead in the unfolding of a pandemic. Dr. Levine, throughout the COVID pandemic, your leadership and dedication to the health of Vermonters was evident in the development and execution of Vermont's emergency crisis response, resulting in outcomes that were far less severe than those seen in other states. You served as a leader for Vermont's collective response by coordinating the actions of public and private organizations and implementing plans and programs to improve surveillance, efforts that recognized and responded to the unique challenges faced by underserved and vulnerable populations. Perhaps most important, you were a steadfast voice of evidence-based, data-driven information which helped to inform and educate everyone, from policymakers to hardworking Vermonters. Your voice at press conferences and your calm demeanor each week was one of reason and assurance. We are pleased to celebrate you as a public health leader who has demonstrated commitment to advancing health equity through strategic partnerships and work to expand public health infrastructure, information, and education. It is our intent to acknowledge and appreciate the critical role you have played both before and during the pandemic. And so it is with sincere gratitude and respect, the board and the membership of the Vermont Public Health Association presents you this award. And it says, the Vermont Public Health Association proudly proclaims the title of Public Health Champion to Mark Levine, MD, Vermont Commissioner of Health, for his long-standing commitment to public health and his inspiring leadership during Vermont's COVID-19 pandemic. Dr. Levine.
Thank you very, very much for this honor. It really means so much to me, especially because it comes from both my current and actually newest professional home, the public health community. All of you truly know the needs of the population before, during, and after a pandemic, and the challenges that public health always faces and tries to overcome. Now, truth be told, by being here in person to accept this award, I do so cognizant of the fact that I will be missing a crucial Boston Celtics playoff game. My wife will recall a day decades ago in the month of May when I almost didn't accompany the stretcher into the delivery room for a similar reason. Now, before you question your initial judgment and retract this award, please understand I'm telling you this only to frame the concept of team play, which my beloved Celtics are illustrating to such a high degree in this era of NBA superstars, who are often expected to single-handedly lead their team to glory. Public health knows all about this very well. You all know about Public Health 3.0, which of course is the contemporary definition of public health and acknowledges just what I heard in the presentation, that public health cannot effectively accomplish its work without intersectoral partnerships and collaborations. So the same is, of course, true during a pandemic. And I would not be here to accept this award without the incredible efforts of abundant teams, starting, of course, with my #1 team, the Vermont Department of Health. All of those in our central office and across our district offices around the state. Their commitment to Vermonters' safety in this perilous time, their steady, data-driven leadership and approach, their tenacity and dedication in the face of truly chaotic and stressful circumstances, their creativity, their stamina, and subject matter expertise, their willingness to stretch beyond their boundaries and be innovative, and their dedication and spirit of self-sacrifice and loyalty to me and the Department of Health's mission to promote and protect the health of all Vermonters. And that's only the tip of the iceberg, so much more than any leader could have asked for. I couldn't begin to do my job as Health Commissioner without the extraordinary effort given in this most challenging time by every member of the Health Department team. So, to VDH, if I could adapt the words of Freddie Mercury and Queen to the name of this Public Health Champion Award, we are the champions. Now, there are plenty of other teams in keeping with that theme, all across the Agency of Human Services. Collaborative working relationships enabled really critical, often life-saving work to occur. Mental health, Department of Vermont Health Access, corrections, Dale, children and families. They joined the emergency response and they partnered with us in areas as diverse as keeping long-term care facilities and psychiatric facilities safe, correctional facilities, perhaps the only state in the country without a fatality, telehealth viable, the child care sector operational, and so much more. And of course, we can go to teams across the broad swath of state government and the private sector. And my colleagues and I at the Agency of Human Services met regularly with public safety, transportation, AOE, education, community development, literally every aspect of government. And God forbid I leave out the National Guard, partners in so many portions of the pandemic, more than you'll ever believe, and hopefully you'll hear about that in a few moments. Whether we were shutting down the state or more enjoyably pivoting to reopening and restarting Vermont, everyone brought their expertise to the table. And of course, I have wonderful colleagues in the governor's COVID-19 leadership team who advised the governor, supported sound public health guidance uniformly, and operationalized the governor's policies. And of course, we all owe a great debt of gratitude to Governor Scott, who steadfastly has remained dedicated to a science and data-driven approach without the admixture of politics we see all too often across the country. I want to thank him for his listening skills, for hearing me, our state epidemiologist and our data teams, and his thoughtful questions and critiques that helped us develop and implement what Dr. Fauci has referred to as an exemplary response to the pandemic, a model for the nation. Now, I'd like to thank Vermont PHA and the way they worded aspects of the recognition for this award, because it does recognize so many things I really hold very dear to my heart in leading the Department of Health. The importance of advocating for preventive health practices in primary care and understanding the importance of integrating the clinical world with public health. The critical nature of having a strong emergency preparedness and response arm of public health, whether we're talking a hurricane, ricin, or a pandemic. The need for robust partnerships and collaborations and coordination across multiple public and governmental sectors and private. And the need for accurate, timely, decision-driving data and surveillance, and a commitment to the practice of what I think we all like to call evidence-based public health that especially shines a light on healthcare disparities so as to advance health equity. Now, I can't stop talking without having a slight look forward and charging you as well as us with a number of important tasks, because this is going to be a very challenging moment in time for public health. We actually have to lead the recovery and revitalization process, which means walking and chewing gum at the same time in more areas than one could possibly imagine. For instance, tonight's topic, mental health, for adults, for children, and integrating it with primary care. Diseases of despair, with, of course, opioid overdose deaths and suicides leading the pack. Health debt, the accumulated negative impact of the adverse lifestyle choices so many of our population had to choose, in a sense, that will impact morbidity and mortality from chronic disease for years to come. The pandemic of long COVID. Climate change as it pertains to providing fertile ground for future pandemics and how it will impact our collective health for generations. And then not to mention issues that are very specific to public health, like the impact of the pandemic on the public health workforce's own mental health, well documented by CDC across the country. The strategic expansion needs of the public health and healthcare workforces, data modernization, and more secure emergency preparedness for the next events, the crisis of misinformation. That's just a few. So our work is cut out for us. Thank you so much for this award. It is inspiring, motivating, and deeply appreciated.
Hello, it's so good to have you here participating with us. I'm Joyce Gallimore, board member of the Vermont Public Health Association, and it's my pleasure on behalf, she keeps us straight. It's my pleasure on behalf of the board of the Vermont Public Health Association to award a Public Health Champion Award and recognition to Wendy Walsh for her extraordinary work in the field of public health in the state of Vermont. This award honors Wendy Walsh for her 44 years of service to Vermonters as a public health nurse and staff to the Vermont Department of Health as she assumed increasing responsibilities to meet emerging needs. Most recently, she has served as co-leader of the department's outbreak prevention and response team. In that capacity, she coordinated dozens of public health nurses across the state to be the local points of contact and guidance for schools, businesses, healthcare organizations, and and living facilities, congregate living facilities. Those facilities and the staff were navigating through the COVID-19 cases that impacted their organizations and the clients they served. Wendy Walsh, with this award, we recognize your role as a healthcare provider. Throughout your distinguished career in clinical and public health nursing, you've applied your expertise, commitment, and caring to the benefit of Vermonters. Your dedication to public health is evident in your work, advocating for health equity and justice through health education, policy development, collaborations between organizations committed to improving health, and the empowerment of vulnerable populations. We are pleased to celebrate a healthcare provider who has advanced health equity by addressing health disparities, encouraging strategic partnerships, working to expand public health nursing, and helping to ensure that children in Vermont get adequate nutrition. Your achievements serve as a model for other public health leaders. We acknowledge and appreciate the critical role of individual Vermonters like you in protecting and promoting optimal health for all Vermonters. Congratulations on this honor and your contributions. We welcome any remarks you'd like to share. The award reads, the Vermont Public Health Association proudly proclaims the title of Public Health Champion to Wendy Walsh, RN, Public Health Nurse, for her dedication to public health, decreasing health disparities, and meeting the needs of communities in addition to her distinguished career in clinical nursing.
Thank you so much. I love being a public health nurse and strive to represent all Vermont Department of Health initiatives in every setting I am in, and just not the programs I cover. I consider my job is to look for ways that the health department can use our resources to help decrease health disparities and meet the needs of the community. And this is achieved by knowing the needs of the community and understanding the data behind these needs. An example of a day in the life of a public health nurse. You never know exactly what will be materialized during the day. You might receive a call from Epi with a TB case, which you might need to investigate. Several nurses could call with questions about things like norovirus, or do you have any information about vaping? You may receive more Epi cases. You have a coalition meeting to attend. Meanwhile, you are reading and answering email and sending out grant information to schools and community partners. I noticed in a school nurse report that all the children in the elementary school had medical insurance, but the rate of their medical visits were very low. Also, the rate of their yearly dental visits was lower than the state average. I worked with a school nurse to understand the data. We determined that the dental data was so low because of how the question was asked, and some parents didn't acknowledge that the Ronald McDonald van had indeed seen their kids twice in that year. I took the data of the medical visits to the local group print meeting. The providers in the area ran their EMRs to capture the data of missed yearly visits and sent letters to the families to call and make an appointment for a well child visit. My role during the pandemic was a combination of all the emergency preparedness trainings I have received starting since 9/11 about biohazard, chemical warfare, smallpox, anthrax, pod trainings, many tabletop drills, SARS, Ebola, H1N, and avian flu. In the beginning of the pandemic, someone asked me about Vermont's response, and I answered, we had been training and drilling for years. We were ready. I had the great privilege of working with outstanding public health nurses, COVID-19 staff, and local district office staff. The public health nurses were integral in our response. They were contact tracers, called positive clients, investigations in every sector. They did vaccination clinics and testing clinics. And I helped train our contractors so that allowed the public health nurses to concentrate on testing and vaccination clinics. Their professionalism and compassion and understanding of their community partners enhanced our collective response during the pandemic. We need to assure a strong public health nursing force for the future. Over the years of my career, I have mentored new staff multiple times and have covered programs in other offices when vacant or extending leaves. The public health nursing staff is having a large turnover, and we need to impart the knowledge we have learned to those new in public health. Thank you very much for this award.
I'd like to introduce you to the individual who will be awarding the group Public Health Champion Award. She is Dr. Mercedes Avila. Dr. Mercedes Avila is a long-standing, passionate, and effective advocate for health equity and social justice. She's worked to secure and implement grants at the state and national level, providing consultation, training, and technical assistance on cultural and linguistic competence, health equity and social justice in healthcare to more than 152 organizations, including all mental health agencies and hospitals in Vermont. She has nurtured and facilitated collaboration through strategic partnerships, and this has helped create a culture of health in Vermont, including expanding community health workers and outreach to former refugee and immigrant communities in the state, and training more than 10,000 professionals across 27 states in understanding the connection between racial, gender, social, economic, educational, and health disparities and the role that social determinants play in health in populations. She is just the right person to present to our next recipients of the year's Public Health Champion Awards. Dr. Avila.
Today, I would like to take the opportunity to recognize a team I strongly believe deserves the Vermont Public Health Association Public Health Champion Team Award. This team is the Vermont Army and Air National Guard COVID-19 mapping mission. Before I describe why this team deserves this recognition, I would like to highlight the Vermont National Guard effort during the COVID-19 pandemic. For the last 2 years, our Vermont National Guard has helped the state of Vermont with COVID relief efforts, running testing and vaccination clinics, leading contact tracing, and most recently, supporting medical facilities across the state when COVID surges took place. Their accomplishments are beyond outstanding. I had the honor of working with them in several initiatives during the COVID vaccination and testing clinics, and what I witnessed was professionalism, integrity, and above all, dedication. The Guard comes to our aid when we need them most. COVID-19 was no exception. Yet, we rarely recognize our Vermont Guardsmen and women who serve our country and communities with sacrifice and commitment to the well-being of every Vermonter in our state. The Vermont National Guard has inspired me daily. I have witnessed our Guard at all times of the day, every day of the week, across the state responding to COVID. The Vermont Army and Air National Guard COVID-19 mapping mission is the team we are recognizing today. The Vermont Department of Health described its team as a team that has led one of the most effective and timely contact tracing initiatives in the country, putting the state of Vermont ahead of almost every other state in our nation. The team has been in operation since November 1st, 2020. Since then, the team completed a total of more than 19,000 index patient cases and more than 23,000 close contacts of the index patient. Daniel Daltrey, Program Chief of Infectious Disease at the Department of Health, described this team, a resilient and mission-driven force that came into the response when we most needed an added depth as our cases were growing exponentially and we were losing critical time. Within a short period of time, we were back on track thanks in part for those who signed up for this duty. The Guard was our Guard and helped us serve Vermonters to our fullest in the contact tracing response. Our Vermont National Guard truly helped put our Vermonter contact tracing response ahead as one of the strongest in the nation. The non-commissioner officer in charge, Master Sergeant Jonathan Mays, who is here tonight, shared that the Vermont National Guard contact tracing team restarted with just 7 members that had previous experience in contact tracing. The team grew to 34 full-time callers and then a total of 64 members since the start of the mission. Master Sergeant Mays described their work as an investigation to reach out to the index patient and find out how they may have gotten the virus, who they have been in contact with during the period of infectious period and whether they had been in school or to work. The most important part of the investigation is to find out how they are feeling and if the index patient needs any resources to help them through their isolation period. There have been times that the investigation and the investigator and the index patient may not even speak the same language, so the team worked effectively with the Department of Health, interpreter services to ensure all of the information was gathered and relayed between the two individuals accurately. The 64 team member showed great empathy towards the index patients at all times and always spent the extra time on the phone if they felt like the index patient needed it. COVID-19 has resurfaced many things about our society and our country, but one that we should value, respect, and recognize are the Vermont National Guardsmen and women that tirelessly work daily to keep us safe, run COVID testing sites, run COVID-19 vaccination clinics, and lead contact tracing efforts that have reached more than 42,000 community members. The Vermont National Guard members put themselves and their loved ones at risk daily for all of us to ensure we can be safe and are able to access resources during one of the most complex times in our nation's public health. I cannot think of a team more deserving than the Vermont Army and Air National Guard COVID-19 mapping mission. Thank you for saving so many lives in our state, nationally, and across the world. Congratulations for a well-deserved recognition. And we would like to invite the four of you, Lieutenant Colonel Risacker, Captain Plant, Master Sergeant Mays, and Master Sergeant Langfield to the podium. Thank you. The Vermont Public Health Association proudly proclaims the title of Public Health Champion to the Vermont National Guard COVID-19 mapping team for their relentless dedication to providing innovative and critical services during the COVID-19 pandemic for the state of Vermont. Thank you again.
Well, the Boston Bruins aren't playing tonight, so I can stay up here and talk all night. I'll have to rewind to that November of 2020. I'll never forget, I asked for volunteers for something called voluntary COVID mapping. And more than 40 signed up, but 40 of us showed up. We have no idea what we're doing. So we assembled in a small room and found out basically we were going to be case investigators. So mechanics, infantry men and women, even intellectually challenged pilots got together, and we learned that contact tracing, or voluntary COVID mapping as we were going to call it, was typically something that came with a bachelor's degree maybe, and 6 months of on-the-job training. Well, in 3 days we figured out how to do it and started making calls because this was an emergency and we declared war on COVID. At the time, it was the first time there was a case backlog, so if you can imagine getting 300 cases in a day when the great members of VDH were covering 100 or 200, it can become an exponential problem. So if you leave 100 cases overnight, 300 cases the next day, now you're 200 cases behind, and we couldn't let that stand. A quote from the Battle of Gettysburg, the first one. The first order was put the Vermonters ahead. And I don't think that was because of our great numbers or Vermont skills or special equipment, but our Vermont military has a certain can-do attitude, and that's what got us through this. So as the team got started figuring out how to do this and getting our training in 3 days and making phone calls, it was that can-do attitude where as the workday would come to an end around 4 or 5 and the case assigners needed to sign out, our folks were begging for more cases so that they could keep making calls until folks went to bed. And when case counts were bad, they worked often 12 hours a day, 7 days a week, for weeks at a time, including Thanksgiving, Christmas, and New Year's. And that got the case count back to 0 overnight, almost every night. So that was such an important thing to allow every Vermonter to know either they had COVID or they had been in close contact, depending on how that worked. Real quick, a day in the life, what is case investigation? So you get assigned a case, you do your pre-interview workup, where you figure out the person, their date of infection, and come up with the window of when they can infect other folks, when they need to isolate. And then you try to contact them. So basically, you're a telemarketer calling from an out-of-state phone number, trying to make contact, and you can't leave, based on HIPAA, a voicemail telling them that they have COVID. So please call me back. Then you finally make contact, verify their identity, and start the interview. How you doing? Do you know you have COVID? Build rapport. What do you need from VDH? How can we help you? Once you make friends, you start the hard part. Who have you been in contact with? Please give me their names and phone numbers. I'm going to give them a call. And oftentimes, since today's theme is mental health, we find ourselves inadvertent and untrained counselors. I remember talking to a gentleman who had already been at home alone with no family. He was a general contractor and couldn't work. He got COVID somewhere. It was actually a very short contact tracing interview. He had been in close contact with no one. But I talked to that gentleman for more than an hour. I can't remember about what, but he was scared and lonely. And other cases are a bit of a friendly interrogation. I remember one young woman in January of 21 who said, "Nope, I have no close contacts." And so we chatted for a while. I said, "You haven't been anywhere?" "Well, went to a couple events." We talked about 6 feet in 15 minutes and how that works and it's cumulative. She said, "Well, there might be a couple. I did go to a Christmas party and then a New Year's party." That was a long phone call. I ended it with 22 close contacts. And then I had to call those close contacts. And I'm sure these gentlemen have some crazier stories. I encourage you to ask them later. And thanks for the case numbers, Mercedes. More lately, we're approaching 50,000 patient interviews, and about half of that is COVID positives, the other half being the close contacts. And that number by itself is pretty shocking. I did the quick math. That's 8% of Vermont. It's pretty staggering that the team of just the Vermont National Guard has talked to that significant number of the entire state. So I know I said I'd talk all night, but I won't. The last thing we learned is whether it's in combat or battling a pandemic, never declare victory. We did once and we stood down the mission. We're here again, still doing contact tracing, but never declare victory, whether it's combat or a pandemic. So ever be vigilant, continue to be in Vermont, and put the Vermonters ahead. Thank you.
I just realized when I was sitting there in my seat, I should have been figuring out what I was supposed to do next, but I was really just listening to those stories and those presentations. It's just, all I can really think and say is, wow. I mean, from hearing from the Commissioner of Health to a 40-year public health nurse working on the front lines to hearing from the National Guard COVID mapping team. It just makes me so proud to be a Vermonter, to be part of a group like this, and just thinking about how big the public health tent is. It's really special. So just want to give another round of applause for all the public health champions. So I want to move on now to we've taken care of 2 of the 3. We've had a business meeting, we've had dinner, and we've recognized the public health champions. Now we're going to move on to the part where we were going to have a panel discussion around mental health and youth mental health. Oh, yeah. Almost forgot something really important. See, I knew I should have been looking at my itinerary. There's dessert. Should we do dessert and then introduce the panel? Yeah. Yeah, I almost messed up really bad and got in the way of people's dessert. So let's get dessert. Again, orderly. Let's try not to hurt each other now. And then we'll engage with the panel discussion. So, yeah. Oh, boy. Okay. So if we have people that are gluten-free, can ask for the House to help with that? Yes, because the cake apparently, yeah, we can take care of it. We were supposed to have a gluten-free cake, but apparently we don't. So, okay. All right. I mean, we're going to be adaptive. We've got the National Guard here. If we really need to call it a crisis at this point, we can. I'm sure they can take care of this. Maybe. But you said you had that can-do attitude, so. All right, so let's grab dessert, and then I'll introduce our panel moderator. Okay. Allison Crumpf, who is the Deputy Commissioner of the Vermont Department of Mental Health. Prior to joining the Department of Mental Health, Allison worked as a clinician at Memorial Sloan Kettering Cancer Center in New York City. I've been practicing that. And she worked for over 15 years developing community-based mental health services. Prior to becoming the Deputy Director at the Department of Mental Health, she was the Director of Quality and Accountability and served as the Senior Policy Advisor in the department. She also served as the co-chair of the AHS Suicide Prevention Committee and the Child and Adolescent Needs and Strengths Implementation Team. It's my pleasure to welcome and introduce Allison Crumpf.
Thank you. I really appreciate everyone coming today, knowing that the topic is mental health. Obviously, that's something I deeply care about in my role. I'm not going to take too much time because we have some really important people here who are going to speak to you about their different perspectives on the issue of mental health, barriers, issues, opportunities, and where we want to go from here. I will say, since I'm a room of public health folks, that when I think about and hear my bio and where I came from, I just want to highlight for everyone that my husband and I weren't Vermonters, and after getting our master's degree, we were looking to decide where we wanted to move, and we had lived in lots of different places, and it was actually the promotion of Vermont as one of the healthiest states to live that kept coming up over and over again that got it on our radar. So it matters, and so I just wanted to highlight that story for a room full of people who probably had a lot to do with that. So it's my pleasure to introduce Christy Hummel. She is an Ending the Silence coordinator for the National Alliance on, is it really mental illness still? Sorry, I just noticed that. And Christy's going to share her own personal story and lived experience. And so she's been a wonderful voice for some of the voiceless in Vermont over the past few years, and it's our pleasure to have her here today.
Thank you for that lovely introduction. You can go to the next slide, please. So my name is Christy Hummel, and I'm here today from the Vermont chapter for the National Alliance on Mental Illness. We are the nation's largest grassroots mental health organization. We are a nonprofit group of local community members who want to help support, educate, and advocate for local community members, Vermonters' mental health. So lived experience is one of the keys to our organization, which leads me to why I'm here today. Next. So that's me. I am NAMI Vermont's Youth Outreach and Ending the Silence Program Coordinator, and I have been a volunteer NAMI In Our Own Voice speaker and trainer going on for about 5 years. In Our Own Voice is a NAMI program where people with lived experience with a mental health challenge share their stories during a live presentation. So I'm not just here to talk about NAMI Vermont programs. I'm also here as a person with lived experience to give you a patient perspective, or at least this patient's perspective. My journey began around age 8, and I began self-harming throughout elementary, middle, and early high school without my family knowing that I was struggling. When my parents and the school found out, I began treatment, and my first psychiatric hospitalization was at age 14, where I was put on medication. And after about 20 years of the medication roller coaster ride and therapy and treatment, I was told that ECTs, electroconvulsive therapy treatments, were one of my last options. And so I eventually got to a point in my life where substances became a way for me to self-medicate, and I decided that I wanted to end my life, that the pain of living was worse than the pain of dying. And so I was very lucky that I was found and that I'm here today. And I came to Vermont at age 32 for long-term residential care following that suicide attempt. And I decided to stay in Vermont because of the network that I had created here and built here as a part of my mental health treatment. So I was able to establish weekly therapy, get a psychiatrist, have a dialectical behavioral therapy group through my county's designated agency, the Clara Martin Center. I found a 12-step program. I even started a meeting out in Thetford, Vermont, right before COVID. Just my luck. But so anyway, but I did really well here for 3 years, and I got married, and I wanted to have a baby, and we went to my psychiatrist. I went down on my medication, and within 2 months, I had spiraled, and I tried to take my life again. And I spent the last 3 years kind of dealing with the consequences of that suicide attempt and trying to rebuild, and all of that through COVID and living alone. So one of the things that has helped me the most in my recovery is the part-time work that I'm now able to do for NAMI Vermont, and I still do the volunteer part too. Next slide, please. So I just want to mention the Ending the Silence program that I'm the coordinator for, especially, not just because it's my baby right now, but because I wonder how it would have changed the course of my life. Being 8 years old, not having the language, not knowing the resources, feeling some kind of shame for some reason, and different than my 2 sisters, was a real struggle, and a big portion of my childhood was spent secretly hiding. And if someone had come to my school, even if it was for 45 minutes, and talked about what mental health was, what coping skills were, who to go to for help, and that I wasn't alone, I wonder how it would have changed the trajectory of my life. And so this is a free program. It's specifically for middle and high school students in Vermont. 2 presenters, people just like me, share relevant parts of their mental health story during an informative PowerPoint presentation. The school classroom teacher and the students, they all get resource materials, and scheduling can actually be done right there on our website. Next slide, please. So this is just an example of a slide from the Ending the Silence presentation. So if I were one of the presenters sharing, I would present this slide and I would share with students that I was part of that 50%, and that I might even give an example of some of the stigma that I faced or even currently face. Next slide, please. This provides students with legitimate ways to help those struggling, whether it's themselves or a friend. And I might share with teens what my friends did for me or what my friends currently do for me. Next slide, please. And I'm really proud of this because every student gets one of these cards. It's about the size of a postcard, and you can tear off the side. And it has Vermont's crisis hotline, the text line. It has all kinds of different resources on it that students can use or give to people themselves. So it's again, it's something that, next slide, please, that I feel like could really help ultimately. So I have a master's degree, and I was a first grade teacher for about 10 years in New York State. And that was right before I hit my crisis, and then I left New York and came to Vermont. But I am a true believer in early intervention. And if we want to change the way society looks at mental health and the stigmas that we're currently up against, then I feel like if we start young with our kids these days, that we can really make an ultimate change and difference. And so this slide is just a bunch of all of NAMI's programs that we have here in the state of Vermont. It has our support groups, which are free. You can train to start your own support group. It has our education programs. Mental illness and recovery. The family at a family class is really great if you're a family member with a loved one who's struggling. And then we have our presentations that I mentioned both, and our work with Homefront. So with all of that said, Vermont has some great resources, and NAMI Vermonts are free, which is really great too. But I feel from the patient perspective that we are still lacking sometimes as a community for more. And I understand that a lot of that has to do with cost. And I feel like for the patient, it's also not just cost, but access to these free programs, access to health care, and then also having that in a timely manner. So from someone who lives with an illness chronically and who's been in periods of crisis, having that access in a timely manner is really important. And I understand that that's a lot to ask you all. And I am lucky, very lucky, that I have Vermont Medicaid right now. And they have helped to organize giving me free rides to Dartmouth Hitchcock Medical Center to get esketamine treatments, and Medicaid is helping me to cover that. And if I didn't have those things, I couldn't be getting that kind of treatment, and it's been helping me. So I'm incredibly grateful, and I understand that it took a lot of personal effort for me, and I had to be an advocate to do it, but I couldn't have done it without the help of my community and with my family, because we had to break that cycle where I would be in crisis, I would be hospitalized, inpatient for a week or so, and then shoved back out into the community. And going back to real life as though nothing had happened. And so the long-term care that I got in Vermont cost my parents out of pocket. I'm incredibly lucky that I have a supportive family who could do that for me. But it would be great if we could help to address that. And I know that you all are working really hard to do these kinds of things. So I just, as a member of the community of people who struggle with a mental health illness on a day-to-day basis, I thank you. All of your individual hard work helps us, and we need you. And it's the community here that's really helped me. So I just want to say thank you, and if you can go to the last slide, please. I would be more than happy to answer any of your questions. I'm an open book, whether it's from a perspective of a patient, whether it's from the perspective of someone who's also in the trenches with you, trying to make a change in the mental health world today in Vermont. Specifically. So thank you very much for having me here and for having NAMI Vermont. Thanks.
Thank you so much, Christy. Okay, I'm going to introduce our next speaker, Dr. Haley McGowan. And Dr. Haley McGowan is the co-director for the Child and Adolescent Psychiatry Consult Service at the University of Vermont Medical Center. And can I add now that we've stolen half of her time, or part of her time, to be the new Children's Medical Director at the Department of Mental Health, which is going to allow her to take that real-world expertise, the invaluable conversations with patients on a day-to-day basis, and bring them to a more population health lens. So we are thrilled to have her. Thank you.
Okay. Thank you, everyone, for having me. I'm thrilled to be here. As she said, I'm the co-director of the consult service for child psychiatry at UVM Medical Center, which means that my job is based in the emergency department and on the medical floors. And so about 2.5 years ago, UVM created my position to better serve the mental health needs of kids in the community. What that also means is that I was the first child psychiatrist ever based in the emergency department. And I guess on a more personal level, it means that over the past 2.5 years, almost every child who's boarded in the emergency department has been my patient. So that's hundreds of kids. And that energy, I guess you could call it, that comes from that is what's really fueling me to want to be involved on a systems level with DMH, for example. So If we could go to the next slide. Oh, you can't really see that very well, can you? That was really just highlighting the objectives for today. And I think what I'd like to do next, go to the next slide, please, is paint a picture for you of a kid we might have in the emergency department that is not uncommon and it highlights a handful of barriers, but also suggests some intervention points that don't necessarily have to do with inpatient care as well. So I thought I was going to be clicking these myself, so I apologize in advance. He's going to have to kind of keep up with the pictures a little bit. But so I'm going to say Addie is a 14-year-old girl, presents to the emergency department following a suicide attempt by overdosing on Tylenol. Shortly after taking the pills, she told her mother, who called 911, and she arrived via ambulance. Fortunately, Addie did not take enough pills to require medical admission to the hospital. She was able to be observed in the emergency department overnight and then was medically cleared. At that point, she was assessed by First Call, which is our crisis team in Chittenden County, and then child psychiatry. And as with every kid, there's so much to the story, but I'll just highlight a few salient points. Addie has been depressed for many months, but has not shared the depth of her struggle. She's been more withdrawn, both at home and at school. She has a 3-year-old brother with autism, whose name is Jake. Addie adores Jake, but his needs take a major toll on the family. If we could go to the next slide, please. So Jake qualifies for an individualized education plan, or IEP, but he can't attend preschool, despite that it would greatly help him because the district does not have the resources to provide what he needs, the specialized care that he needs. He currently gets a few hours of autism targeted care a month, and that's it. So this places a major toll on the family. You can hold off right there for 1 sec. Thanks. Major toll on the family. Addie and Jake's mom stays home full-time to care for Jake, who requires most of her attention. Dad works full-time. During the pandemic, most of Jake's intervention has been remote, and what that means is much of it has been on mom's phone because the only other phone in the household is the Chromebook that Addie gets for school. Remote intervention has been quite unsuccessful for Jake, as it very often is for kids in this situation. Addie spends a lot of time on her phone in her room as she withdraws. So the kids manifest stress in different ways. Jake understandably externalizes and can be aggressive at times. That's the volcano. And then Addie internalizes. She comes home after school, doesn't socialize much, has very low self-esteem, and has a hard time imagining a future for herself. So once a good student, her grades have also started to decline, and teachers have contacted her parents noting this. She imagines that life would be easier for her family if she weren't around. So back to the emergency room. Addie is very depressed and lonely, if you can go to the next slide, but regrets having taken the overdose. She recognizes that something needs to change and wants help. Referrals are made to Vermont's limited inpatient options for stabilization, both inpatient psychiatry and hospital diversion programs. She waits in the emergency room for 8 days. This is, needless to say, counter-therapeutic, and many times throughout this stay, she questions whether she really wants help. Her parents hear every day that a bed is not available and question whether this is doing more harm than good, which sometimes it does. Finally, on day 8, Addie's transferred to an inpatient psychiatry unit. With the help of psychiatry, social work, a therapeutic milieu based largely on group work with peers, Addie learns about her depression, begins to develop coping skills, and is future-oriented. She happens to be started on medication. She's just charged after 7 days, shorter than the amount of time she spent in our emergency room. And she, perhaps the clincher here is that she leaves the unit, the inpatient unit, with the same support she had going in. And that's a school counselor and her PCP, though she now has a place on several months-long wait lists for mental health treatment. So there are countless versions of this story that land kids in the emergency room. The most common presentation is suicidal thoughts or behavior, but others include agitation, aggression, psychosis, mania. Exposure to trauma, often lifelong intergenerational trauma, is a common theme. You can go to the next slide. So in the interest of time, I'm not going to read through statistics, but they really do speak for themselves. I can highlight a few. Percentage of high school students who report persistent feelings of sadness has risen from 26% to 44% from 2009 to 2021. The bottom stat there is 2021 survey by the Vermont Youth Project. 1 in 2 Vermont high school students say their mental health has declined because of the pandemic. And the slide to the right is from 2019, just a few statistics for the state of Vermont about the number of Vermont kids who felt sad or hopeless, made a suicide plan, attempted suicide. The numbers are pretty shocking, to be honest. You can go to the next slide. This is just a collection of headlines that I won't belabor from across the country, including VT Digger up there. It's gotten to the point in some states where the state has declared a state of emergency related to child mental health. Next slide. So this is actually a New York Times article from this past Sunday that some of you might have seen. It actually quotes my colleague and friend, Dr. Christian Pulcini, who's an emergency medicine pediatrician at UVM, a true colleague in child mental health, I will say that, or an ally. In the article, they also link to a study we recently published on characteristics of teens boarding in Vermont emergency rooms. It's covered 11 of our 14 hospitals in the period from June 2020 to May 2021. The most common presentation by far was suicidality. The average length of stay at that time was around 3 days in the emergency room. This is decidedly higher now. I don't have updated numbers, but to give you an example, I testified for the Vermont legislature back in February, and that week, it was convenient for the testimony, there were 11 kids boarding the emergency department with an average length of stay of 11 days. So I think for those of us providing clinical care, the hardest part is that we know what these kids and families need. We've been trained to know what they need, and we know what's evidence-based, we know it works, we know it can dramatically alter lives, and we aren't able to provide it to them. So that's a lot of bad news, but it's not all bad news. You know, I haven't exactly been cheerful, but I am hopeful. I think if you could go to the next slide, please. There are some really exciting things happening in Vermont. Some are in their nascency, some are, further along. Mobile crisis development, suicide prevention initiatives, integrative care, integrative mental health care and primary care, hospital-based improvements, some of which we've done, just trying to soften the experience of boarding in the emergency room. It helps, but it's not a solution to the foundational problem. But the best way to encapsulate what Vermont needs is a continuum of care that doesn't really exist for child mental health. I'm sure missing things, but kind of gives you an idea of all the things I'm talking about. There's a lot of headlines about inpatient beds, but it's really just a small part of the bigger picture. There are lots of intervention points, and if you think back to Addie's story, there were probably 6 or 7 we could identify just from that story that might have kept her out of the situation she ended up in. Next slide. So brainstorming solutions and interventions, these are just a few of the things I tend to focus on. I'm running out of time, so I'm going to go very quickly. Partial hospitalization and intensive outpatient programs. So these are programs where kids, they provide intensive mental health treatment, but kids sleep at home. They're not inpatient beds, and you can do really wonderful work in that setting, and we don't have it here, hardly at all. It barely exists, and I would say a gigantic majority of the kids that we see in the emergency room could do without inpatient if we had other options, but there's really just nothing in between. Far more intensive, so brief crisis stabilization programs like PUC, which you guys may know about, intensive home-based RAP services. I've heard that Vermont used to be famous for this, for RAP programs, and the system is pretty decimated at this point. I mean, there are people working very, very hard, but the wait lists are incredibly long, and that's another thing that really does keep kids out of emergency rooms and out of crisis in general. And then workforce development and retention. This is very complicated and emotionally grueling work that people are doing. And if we want to keep these talented, caring individuals in Vermont, we need to train and compensate them in a way that's motivating and really makes them want to stay here. So, and that's, I'm not talking about physicians at all. I'm talking about, crisis workers, first responders, therapists, skills workers, family-focused treatment services, essentially. So, I'll end by saying I think these are really difficult times, but I remain hopeful. I think the right conversations are happening. And Vermont is not alone in what often feels like an insurmountable challenge. This is very much a national story, but we are a small state and built on community and relationships, and this is the same way I ended the testimony. It really feels like it could be different. I feel like we could be a gold standard, but it takes the right vision and allocation of resources commensurate with how we value this next generation of rising Vermonters, and we could be an example of what's possible. So, thanks.
Thank you, Dr. McGowan. Okay, I'm pleased to introduce to you Katina Idle. She is a licensed clinical mental health clinician, an ARC trainer for Lamoille Community Connections. She has years of experience working with children and families in a variety of school settings, and is a supervisor to the school-based clinicians in her region. Thank you.
So this is actually a perfect setup to talk about what I want to talk about now. I'm honored to be here tonight, but the only way that I am here is because of my team. So I have 11 school-based clinicians that I supervise in Lamoille County, Their positions are contracted by the local schools. So we provide clinicians to provide services in school for kids. And it's not a separate standalone service. It's actually integrated. We want to do systems change. So we're doing individual therapy, we're doing group therapy, we're doing family therapy, we're connecting to further resources. We know that the past 2 years have been unbelievable, right? 3 years, I guess we should say now. And the biggest thing about school-based mental health is not just the kids. The kids are super important. But what it is really is the next slide. Just like in all of your hospitals, the frontline workers. I mean, so it is a huge, tremendous thank you to all of the school staff, to all of the parents, to every caregiver out there who has helped support kids to get through the past couple of years. I can't even imagine what I would have done. I'm a parent, and we went remote, right? A lot of you were parents. You went remote. You had your kids at home, and then school went back in session, and you helped make school go back in session. And that was huge. But then we kept having to pivot, right? And that because of what we were living through with the pandemic. We were out of control. And when we get out of control and our lives are threatened, we have a constant chronic state of stress. And constant chronic state of stress leads to ACEs, right? So we're looking at not just the mental health, but the physical health piece that's coming into play from these past couple of years. Next slide. If we really want to help the kids, what research shows us is we need to help the grown-ups. The biggest protective factor to ACEs is a positive, safe relationship. So if we want to be able to help our kids get through this and come out the other side healthier and happier, we need to take care of ourselves and our educational workforce. We know there are staff issues everywhere. We're looking at a turnover rate in the education sector of almost 70%. That's burnout rate, but we're also looking at almost a 70% turnover rate in some of the positions in schools. So when she just highlighted there isn't one-on-one supports for kids in schools, that's true. We can't hire for kids. We can't hire for the one-on-one supports right now because the direct work is so hard and it's so taxing. And you're putting yourself in the front line every day. You're being exposed to COVID by 300 plus kids in that school every day. So that's not always the happiest job. Next slide. This is from our own Vermont PBIS, which is a wonderful, if you don't know about them, Vermont PBIS is a huge supporter of the AOE in terms of positive behavior intervention strategies. How do you get in front of a problem instead of being reactive to a problem? The problem here is that this was not a recovery year, as many of you had said before. We had hoped it would be, it was not. So just like you're running that last mile and you're like, oh, I'm almost done. And then you're like, oh, oops, I'm not. Now we got another 500 to go. Sorry, you can't take a break. That's how our educators felt. That's how our parents felt. That's how everybody felt. So we really need to respect that. And then thinking about what are we going to do with that? We've all experienced difficulties. We've all experienced chronic stress in the past couple of years. We'll go to the next slide. So if we want to go from ACEs, we want to go to PACEs. So yeah, next slide, please. And I'm not sure if any of you have seen this yet, but the PACEs connection. So what can you do about positive and protective factors against ACEs? Is we really need to look at the big picture and the roadmap. And we want to have a more trauma-informed society, right? So we're aware, I think everybody's aware, right, that things have been rough and people have had hard times. So we have to move from being aware to being informed, and then actually beyond that to being PACEs informed. What can we do to get back on track? What can we do to get in front of this? What can we do to build resiliency? Next slide. If we want to create resilience and promote that in our students, these are the 3 things we need to do. But if you look at these 3 things, none of us got to do in the past couple of years. Connect, encourage, and involve. So we need to be able to come back down to some basic relationship building, and that means managing our own caregiver affect management, reducing our own stress, engaging in our own healing, so we can show up for our kids. Next slide. All right, so these are some great resources. The PACES Connection, the SEL Signature Practices Playbook. This can go right to schools, right to AOE. We don't have to reinvent the wheel. There are things we can do right now going into next school year. ARC training, that's about trauma-informed evidence-based treatment, and it really focuses on attachment, regulation, and competency. So again, first step is attachment, relationship. Then interconnected systems framework. There's the AWARE grant. I'm not sure if many of you have heard about that, Advancing Wellness and Education. There is a federal funding grant that uses the interconnected systems framework, which fancy way of saying education, mental health, work together. And it works. And then SAMHSA came out with, and I'm not sure if you've seen it, but a trauma-informed approach to workforce. So this is actually a tool that is available to everybody, and again is a great guideline if we could bring this into the workforce as well. So thank you for your time. There's a lot, but I do have a lot of hope, and I'd be happy to answer questions later.
Okay, I'm your last presenter before we do Q&A. And as a previous mental health clinician, I would encourage everyone to take a deep breath if you need to, stand up if you need to. I know it's been a long day and we're at the very end of it. So please go forth and breathe, and we'll be doing questions momentarily. So again, I'm Allison Cronf. I'm the Deputy Commissioner for the Department of Mental Health. And my goals here today were to talk about access to care and give you a sense of the system barriers right now and opportunities. So if you go to the next slide. I put this up here because if you Google Vermont access to mental health, this shows up. So this is not us patting ourselves on the back, but to Dr. McGowan's point earlier, we should have the best mental health system and mental health access. We are known for being the healthiest state. And so some of the ingredients on here that make us number one are our insurance coverage, which we've done very well with. We have a high rate of IEPs that identify emotional disturbance. And then you'll notice, you probably can't see this, but it's mostly based on major depressive disorder diagnoses and access to care for that. So I just wanted to highlight that going into this to show you how, as the families that I talk to, the individuals served that I talk to are not feeling this right now. And so some of the nuances are going to be what I'm going to talk about. So if you could go to the next slide. Major issue right now is the staffing crisis. And so I wanted to highlight a few statistics that are fairly dire. Currently, due to the staffing crisis, 52 out of 200 of our adult inpatient psych beds in Vermont are closed. 13 out of 30 of our child beds are closed. And the latest Community Mental Health Agency data indicates that out of the 5,000 positions that we have, over 1,000 are vacant, with around a 31% turnover rate. This leads to increases in the need for emergency services because we aren't able to get out there and get ahead of these needs. It also has issues with 24/7 community-based programs staying open. And those are, I think this is a Mary Moultonism, the fingers in the dam, where, if you don't plug those, it rolls over into needing higher levels of care. And also it leads to very long outpatient wait lists, which Dr. McGowan spoke to. Next slide. The good news is, if you can get in, we are very effective at treating mental health issues in Vermont. This data is actually from programs that Katina oversees. It's our Success Beyond 6 program. That's where our community mental health agencies provide mental health services in the schools. And what I want to highlight here is that out of the 2,640 students sampled here, the highest needs are around anxiety, adjustment to trauma, and attention deficit. Depression's a lot lower. So if we were a little bit more nuanced about how we're getting at the real needs of children and youth, we might see lower access to care. The good news is, if you're in that programming, this data shows from fall to spring of 1 year of a student receiving those services, The impact is great. For if you're 25% of students had their anxiety resolved to a degree where it was no longer impacting their functioning. So we really want to see programs that work expand. Next slide. Let's talk about the role of COVID-19 with the mental health pandemic. I wanted to highlight that mental health in youth was an emerging issue that was being highlighted before the pandemic, and I want to talk a little bit about how it's exacerbated it. Next slide. If you haven't seen this, I highly recommend it. The New York Times did, it's like a 14-minute video, but also an article around the role around youth mental health crisis. And so there's a couple youth interviewed around what is social media like for them. And I just grabbed a few of the quotes because I found them so meaningful. And this youth said, you know, for some folks, the studies are not clear that social media is bad per se, but for some, it can really exacerbate issues. And this youth pointed out that, you know, him and his friends admitted they're miserable, but yet they're out there watching everyone else who's miserable having a good time. And how does that feel? And it really kind of can mess with their sense of perception of themselves. Next slide. I wanted to highlight what this looks like with recent COVID-19 and how it's impacted self-harm. So these are rates of self-harm by age group. And we're seeing a very high uptick for self-harm for ages 15 to 24 showing up to the emergency departments. Next slide. Another point that I really wanted to make, Dr. McGowan spoke to the percentage of students who are endorsing that they've been feeling sad or hopeless. A student is not a student when it comes to the impact of mental health issues right now, and there are disproportionate impacts, particularly for LGBTQ youth and particularly for students of color. Not to mention the intersectionality. If you're a student of color and identify as LGBT, your percentage of feeling sad or hopeless is double, as well as attempts in making a suicide plan. So I really wanted to highlight this point because if we're going forward with building a system that's supposed to be protecting the most vulnerable, we need to be looking at the most vulnerable and the most impacted, and if we can build a system for them, it will better everyone else. Next slide. This is another youth that really impacted me when I was watching her story. She talked about this feeling of going through her high school and learning about what to do and what not to do. And I know how to do CPR, and I know that I shouldn't let my friends drink and drive, but nobody told me what to do if I got a panic attack. And how she really felt like she needed more information about how to manage her emotions and her anxiety. Next slide. So what can we do about that? And what are some of the things that can protect youth? Because things are going to happen. Relationship issues are going to happen. Pandemics, unfortunately, are going to be coming in and out and may be a part of our lives for some time. And so research would say that building connection and having resiliency and community support are major ingredients. Yet more than half of the youth receiving school-based mental health services in Vermont report that they don't feel connected or supported by their community. We also have issues with 42% being not optimistic about their future. And when you think about what it was like being a student the past few years, how can you be optimistic? Because the things that you're looking forward to, you know, we've all had to manage our expectations. You might have a wedding or an event, but you don't want to get too excited because it might get canceled. And if you're a student who's looking forward to a dance or a sporting event. So we've kind of tempered our expectations, which takes away some of the optimism and future orientation for youth. So that's something we need to build back. And then 1 in 3 students identified that they don't have the resiliency necessary to face life's challenges. So the next slide is good news, and I can't help but always put a plug about this. It's the research I'm doing right now in my graduate program, and if you want a clear way to build some of these strengths, music and the arts is a great way to do it. And so as we figure the rest of these issues out, that's just one thing that has all the ingredients to build this up for youth. And lastly, the last 2 points I want to make is there are very good, clear recommendations for what to do to move us forward to a better system. I really want to note, support, and expand the workforce. When I think about how we're going to get the Army we're going to need to deal with this, I think of how we're going to, A, expand the types of roles that help people. I think of peer sports as one major option. I think of integrated health. I'm like very proud to be part of co-leading the Mental Health Integration Council with Dr. Levine, because we know that 85% of psychotropic meds for kids are prescribed by primary care. And yet, a lot of primary care docs report that they just don't feel equipped to manage the mental health needs. So how do we build that up and give them that support? Not to mention, how do we encourage mental health workers to come into the field? And so I can never have a microphone in front of me without saying that being a crisis clinician in Vermont was the best job I've ever had. I highly recommend people coming into that field. I think we need to support those workers with their own mental health and care. We need to thank them, and we need to work on pay disparities and equity. And very lastly, we need to figure out, this last slide, on the next slide, how to pay for it in a way that encourages and invites the outcomes we want to see. And that is all I have for you today. We're open to questions. Thank you.
So we're a little bit behind schedule. We have about 10 minutes for questions and answers, and if you have a question, if you could raise your hand, and we can bring a microphone over to you. It's important because we have people who are watching from home that you speak into the microphone in order to ask your question. Is it on? You could come up here too if needed to, if it's not working, if you don't mind, Bert. Okay. No, the people from home can't.
I think it's on. Okay. So I just have a question about who has been able to do this right. So we have 195 countries in the world. Some of them have excellent, universal health access programs, and I think do a lot in terms of all the components of this with education and treatment and providing the financial resources to cover mental health. Is there somebody there in Europe or Asia and who is really addressing mental health in the way that needs to be addressed, that we can kind of look to for answers for our challenges?
Yeah, I would invite others to chime in, but I would answer it. Unfortunately, it goes back to my last slide a bit, which is how you pay for things sort of makes a difference in that realm. So there are some models that work for certain reasons that we have a different, we don't have universal health care in the United States. And so when you're thinking about, I look to, for example, the VA, that is one place where they've been working to do some like upfront prevention resiliency building that has had an impact on the trauma experience of service members and their families. So that's one place. There's other models that we're looking at in the Mental Health Integration Council, like the whole health model. I know others have gone over to Finland and seen some great things. And then in terms of substance abuse and recovery, in the Netherlands, you might think they have it right. I don't know that we'd be able to plop any of those into the United States, given the scale and the healthcare system and the way that we fund things. But I'd welcome other thoughts.
Every English-speaking country is reporting difficulty with student mental health right now. There's nobody doing that right at this moment in time due to the pandemic. There are countries that are doing a better job with early intervention, and it actually starts when women are pregnant. So if we could get, again, way, way, way in front of it and start doing some better perinatal mental health care, that would be a fantastic start.
There is a United States school report card, mental health report card for each state, and Vermont's doing really well. But it's interesting to see where other states rank and how, and that it's a good resource.
I think of the pandemic as being the great equalizer in that it kind of woke us all to mental health, to our mental health, and we should think about mental health as being health. And so, as I'm listening to everyone speak in the statistics, you know, when we had the pandemic, we had a response, we had the Rescue Act, we had dollars coming in from the feds. How do we use our statistics as a nation to point out that this is now the new public health emergency and try to get that kind of same support behind this effort? Any thoughts on that?
I was just going to answer. I think that's why we're here. Really, that's why we're leading with statistics in meetings like this. You know, I think of Allison I was speaking to about every chance I get, every time I get a microphone or some version of a forum, it's a call to action. Really, you know. So I don't. I guess I don't have any detailed answer beyond that. Do you want to go?
NAMI Vermont has an advocacy group and advocacy programs, and so we have all kinds of petitions and people that go and speak to legislatures and to make people aware of some of the different healthcare issues and trying to get some reform and change made in that. So that can be found on our website.
I would just name that it's both unfortunate. We often have to go to the data point of the furthest spectrum. So I give the example of suicide deaths as an indicator of mental health, and overdose deaths as an indicator of mental health. And that's always been, I've never found that to be satisfactory. However, this year, when you're using those metrics, it is a clear emergency. So I would find that if we can't get folks' attention with our overdose death numbers and suicide death numbers right now, then I can't imagine anything else that would generate that fire.
I was listening to a program that was talking about mental health among healthcare workers and that there's a real stigma around admitting that you might have some anxiety if, say, you're a doctor, because historically, I think sometimes you could lose your position for that. And I think Biden just signed maybe a law like changing that. But I'm wondering how, if that's the case, like how does that trickle down in terms of our health care? And is there work trying to change that within Vermont, or has that already changed in Vermont?
Yeah, I would just what we do know is it is asked as part of a medical licensing board, and we are bringing that up to review because in the way that it's asked, it's seen as a detriment and something that could put their license at jeopardy.
I will say I do think it's worse outside of the mental health fields. And so, you know, my department, for example, I think is very, very welcoming and very eager to help people, you know, find support, find access to help that they need, be honest about, you know, their experience. But that may not be the same in something like surgery or internal medicine. You know, and we try to bridge sort of the departments as often as possible. For example, we interface very closely with peds. Sometimes I feel like I'm with the pediatrics department as much as I am with, you know, with the psychiatry department. And what that allows us is these open conversations, you know, that sort of trickle throughout the hospital system, you know, whether it's with pediatric residents who are struggling or seeing how psychiatrists struggle managing these types of cases, you know, and that it's totally acceptable, you know, and that we need to have open forums, open conversation about it. So my experience around it has actually been pretty positive as a physician, but I know that's not everyone's experience.
Things are different in the mental health field in terms of clinical supervision, right? That is a big part of your work. So you get supervision around your actual work, but then part of your supervision is also around your personal and professional life, right? That is an important part of your training. I think that it's a detriment we don't have more reflective supervision across the healthcare system as well as across the education system. If you could talk about how you're doing and how it might be impacting your work or how your work might be impacting you, we would make huge strides in being able to address and talk about anxiety and depression.
Yes, Dr. McGowan, you talked about child wait times in ED. First of all, I just wanted to say I've been hospitalized several times here in Vermont for psychiatric reasons. I spent one night in the emergency room at CNC, and it was the worst, one of the worst nights of my life. So, and in terms of the children in ED, the latest data that I've heard from the Vermont Association of Hospital and Healthcare System, the data's a little fuzzy, it was about 14 days. It's a travesty. And my question for you all is, of the initiatives and projects and programs that we have right now going on in the state, what do you all think are the highest leverage and most immediate things that we're working on? Thank you.
I would say, I'm going to name first suicide prevention efforts, and I'm going to say that because if you look at the list of children and youth leading, it is majority suicidality and suicide plans. And not all of those youth would need to go inpatient if we had some of those treatment opportunities. And when I say that, I mean treatment opportunities that we're building now. So mobile crisis response would be going out to meet with that family and that child as soon as they even began to have an escalation towards suicidality or first spoke to that need. I think the second is the crisis bed programs. So those are, I've always known that both NFI and the Jarrett House were exceptional resources because I was a crisis clinician at Northwestern Counseling and utilized them all the time because it was hard for families to send a child, and especially sometimes a 5 or 6-year-old, from St. Albans to Brattleboro to get their treatment. Those programs were very hard hit by the pandemic and the staffing crisis. And so if we were able to get them up to full-time staffing, that would have an immediate impact on the numbers waiting. That would be one of the fastest things we can do, and that is a major priority of the department, and we've been bolstering those particular programs with funding. They're getting close. Jarrett House is back to 24/7, which is a huge accomplishment, and NFI is close. So I would name the crisis bed programs as well as intensive services at the community level. And I think we spoke to that before. It's hard to get a RAP program when you have a wait list of, as many as they do to assign as many staff to RAP a child or youth in the community. But when we do it really well, and that can prevent the need for inpatient altogether.
I'd just like to add that our outpatient program is fully staffed pre-pandemic, but the number of people we're discharging has gone way down because people haven't gotten better as quickly because the stressors are still present. So our wait list has gotten very long because new people have come on board to ask for help and support, while the families we have been helping that have very high needs, we can't discharge them because they still have high needs. So it is about recruiting and bringing on more people to help support. It's not that they've all just disappeared. It's that the need has grown exponentially higher and faster than we have in terms of training our staff and hiring our staff.
Yeah, the need has grown as the resources have shrunk. It's a perfect storm, and so I think I couldn't agree more about the staffing of the programs. If almost nothing that we refer to from the emergency department, whether inpatient or outpatient, is fully staffed, and so we end up with very few options because there's just nothing in the middle. There's nothing in the middle. There's an outpatient therapist who's already doing their best, and then there's like inpatient, and as a family really struggling. And so I think if we can staff the shorter term programs, the hospital diversion programs, and the RAP programs, it would go so far. The idea that there's almost 1,000 open positions in the DAs in a state like Vermont is just like shocking. So.
Thank you. So you all have very different kind of perspectives and positions in the field, and I guess I'd just ask each of you if you had a magic wand, if there was one thing, that you wish you had that you don't, and you had a magic wand that you could get, what would it be?
Intensive outpatient and partial hospitalization. Really, it would keep so many kids out of the hospital, and we could do such great work with families it's something, I mean, with the opportunity, I want to run one, really. Like, I've seen, they're magical when they work. You can step up to them, you can step down from them, down to them from inpatient. So I feel like it's a gigantic hole in our system.
Because she took that one, I'll take a different one. I would have time and tools to give to all of our educators, because they are not mental health clinicians, and they keep saying they're not mental health clinicians, and they're right. But they need better training, and they need time to be trained, and they need the tools, and they need somebody to model how to use them, and then the education system would be in a much better footing.
I would, if I had a magic wand, I would ask every Vermont middle and high school teacher to look at their core curriculum standards and see where they can fit in a program, whether it's the Ending the Silence program for NAMI that's free that we do, which you can literally just go to our website and click schedule. You just send me some dates, and I reach out to our volunteers, and we schedule them. I would just magically have our middle and high school teachers schedule us, and if not us, another program like the You Matter training. We can be piggybacked along with other trainings, and but that, and then also our volunteers are so amazing. I would love to be able to do something to give back to them too, because they're using their lived experience and revisiting and sharing and being vulnerable in incredible ways. And so, yeah, that's two things. Sorry.
Yeah, my last thing would be that all organizations, private or not, make the well-being of the people that are employed there a major part of the success of their organization. Because I'm finding that the Department of Mental Health, the DAs, the hospitals, they can't do this alone. And the people who are coming to work every day, who've been going through COVID, the teachers, the parents, they're exhausted. They're absolutely exhausted, and it trickles out. And so we all need to put in that ingredient as a part of success for your organization, so that we can have a net of helpers who have the energy and will to help.
Thank you all so much. We're going to take one last question. I'm very cognizant of the time. We ran a little late in starting, so I do want to be respectful of everyone's evening, and it is 8:30. We're going to take one last question, and then we're going to wrap things up. Thank you.
Thank you. It's not a question. I would like just to add something to help you guys. I think the impact of the culture in mental health on new American community and immigrant community very important. So I suggest you guys to work sometimes with immigrant community. They're gonna help you to have a good approach. As a physician I'm a physician in Congo. I practice a lot. I was doing cataract surgery. Here I couldn't do nothing, but I have my master's degree in public health. So sometimes what we hear from you guys, I would suggest you to work with us to help you guys to improve more. Because the impact of culture is very important. There's some diagnosis you guys you give, it does match with the reality, the conception of disease of African people. Because when someone in Africa has a mental health problem, the family has an impact. The leader of the community, the religion leader, they have an impact to help the patients to improve. But here, you guys sometimes it's like medication. And the results, it's negative. So it's just you guys with all organization, you are doing a good job, but the culture is very important. Thank you.
Well, I think we did all four things. I want to thank our panelists. That was just really amazing. Great perspectives from all around. Thank you so much. And thank you for the work that you do every day to help Vermonters and the Vermont community. So appreciated. Thank you all for coming. It's great to see people again and connect in a way that feels very human. And this has just been really rewarding. One last request, if you will, at your table, there's some papers where we would really like to get you to do a little evaluation. Getting your feedback is really important to us, and will help to make this event that's meaningful in the years to come. Thanks for coming. Maybe hope to see you again next year. I feel like this year was like kind of getting our bearings again to how to be in person and how to organize things, and I felt that tonight really went well. So thank you again so much, and thanks to all the public health champions and our panelists. And I'll see you soon. Bye.
That was great. I feel like that worked really well together without planning it. Like remarkably well. We all like touched on each other's stuff. Yeah. Yeah.